Hello everyone, welcome to Medicine with Shazan. I hope you have watched the previous lecture where we covered localization of neurological lesion in cases of upper motor neuron type weaknesses. In this video, we are going to cover lower motor neuron type weaknesses. We all know that lower motor neurons are located in anterior horns and their axons travel all the way to motor end plates, the muscles. So any lesion at the level of anterior horns and spinal roots, plexus, spinal nerves, neuromuscular junctions, and finally at the muscles. Any lesion at these points will result in lower motor neuron type weakness. So let's get started with our scenario where a patient presents with difficulty in walking. We have already covered the detailed step-to-step neurological exam in the previous lecture. You can watch the video here. In this video, we will quickly do the examination and correlate the findings with the diagnosis. Apply the correct scheme, the algorithm that will help us in pinpointing the exact lower motor neuron type lesion. So the steps are the same. We sanitize our hands, introduce ourselves to the patient, ask for consent, expose them, and then do inspection, proper inspection, fasciculations, assess the bulk of the muscles, checks the tone, power, reflexes, and then sensations and coordination and gait, right? So let's suppose we have already done the prerequisite. So coming to the inspection, when we do inspection, let's suppose there is marked wasting of distal muscles on its both sides. And also there is, you can say, hammer toes on both sides. Now we come to look for fasciculations, and when we tap the muscles, let's suppose fasciculations are present on both sides. We grossly assess the bulk of the muscle, and there is marked wasting. We quickly check the tone. There is hypotonia. We check the power, and let's suppose the power is 3/5 on both sides. And then we check for reflexes, and the reflexes are absent. In lower motor neuron type weakness, or when the reflexes are absent, we need to confirm it with reinforcement too. So I will quickly do the reflexes in such cases. जी अच्छा, मैं ये मारूंगा, ठीक है, आपकी टांगों पे दर्द नहीं होगी, ठीक है. So you tap the tendon. Let's suppose reflex is absent. Now you do reinforcement. You ask the patient to either clench their teeth when you are about to tap the tendon, or they can make a grip like this. अच्छा, मैं 1 2 3 गिनूंगा, 3 पे आपने इस तरह करना है, ठीक है, और मैं यहां मारूंगा, ठीक है. करें, शाबाश, हाथ में करें. 1 2 3, ठीक. So of course this is a normal subject, so the reflex was brisk because he's a normal subject and we are doing it in reinforcement. Without reinforcement, the reflex was normal in this normal subject, but with reinforcement, the reflex got exaggerated. But let's suppose, for the sake of our scenario, let's suppose the reflex is absent even on reinforcement. We do the same here, first without reinforcement and then with reinforcement. अच्छा, मैं 1 2 3 गिनूंगा, 3 पे आपने इस तरह करनी है, ठीक है. 1 2 3. So the reflexes, let's suppose, are absent. Same for the ankle reflex and plantar reflex. So now the answer to our question, where is the lesion? This is lower motor neuron type weakness. The answer to our first question, what is the lesion? Where is the lesion? The answer lies whether the sensations are intact or not. Let's suppose in this particular scenario, the sensations are intact. When we do the coordination, it is intact. And when we do the gait, it is high steppage. Like the patient walks like this, right? High steppage gait. So it is pure motor, lower motor neuron type weakness. Where could be the lesion? It could be either at the level of anterior horns, it could be at the level of peripheral nerves, polyneuropathy, pure motor polyneuropathy, or it could be at the level of muscles. If it is at the level of anterior horns, it could be either SMA, spinal muscular atrophy, or PMA, progressive muscular atrophy. If it is SMA, the weakness would be more proximal. Here, in this case, it is distal. So it could be PMA, more likely. But we will need to do further investigations like NCS and EMG to further confirm it. If it is pure motor polyneuropathy, then it could be the lesion could be either CIDP, chronic inflammatory demyelinating polyneuropathy, it could be lead poisoning, or it could be diphtheria. And finally, if the lesion is at the level of the muscles, it could be hereditary, like limb girdle muscular dystrophy or myotonic dystrophy, in which case there would be facial features to myotonic grip and all of that. It could be inflammatory myopathies. It could be due to systemic causes. But in most cases, it is either at the level of anterior horns or it is pure motor polyneuropathy. Also, it is important to mention here that if it is related to muscles, then in most cases, the weakness would be more proximal than distal. Here, in our case, it was distal. So it is either at the level of anterior horns or at the level of spinal nerves, pure motor polyneuropathy, right? Let's consider another case. The scenario is the same, difficulty in walking, but the findings are a little different. For example, when we do the inspection, no wasting is present, muscles are okay, fasciculations are also absent, tone reduced, power 2 by 5 or 3 by 5, let's say, and reflexes also absent. And again, the sensations are also intact. Now, what could be the cause? Most likely it is acute, because if it was chronic, then we will see wasting. Also, we can ask the details, we can ask the history. And if it is acute on history too, then the cause would be most well-known GBS, Guillain-Barré syndrome, or its variants. Other lesser-known cause could be periodic paralysis, hypovolemic or thyrotoxicosis periodic paralysis. Now let's consider another scenario where the patient presents with tingling sensations in his hands or in his feet. Now we again do the examination. There is marked wasting, hammer toes, or let's suppose even foot drop, bilateral, tone, hypotonia, power reduced, reflexive absent, more, let's say, in the ankle than in the knee. Now, when we do the sensations, pain temperature, or even vibration proprioception, they are impaired. And impaired in the form of glove and stroking pattern. Glove and stroking pattern means gloves in this way, whole, not in a specific dermatomal, and stroking pattern like stockings, all the way from foot upwards, not in any like generalized loss of sensations, not in specific dermatome. So when we ask for sensations, can you feel it? No. And when we keep coming like this, they cannot feel the sensation, or reverse. The pain prick sensations are exaggerated. It could happen too, right? So again, motor weakness along with it, impairment of sensations. So now where could be the lesion? Now the lesion could be either at the level of spinal roots in the form of radiculopathy, at plexus in the form of plexopathy, or at spinal nerves in the form of mixed polyneuropathy, right? Since, as I have already mentioned, the sensations are in glove and stroking pattern. Here, stroking pattern, we haven't checked the hands. So stroking pattern, so it fits with mixed polyneuropathy. As I have already mentioned, the sensations are impaired in the form of stroking pattern, not in any specific dermatomal fashion. Like if it was impaired only in L5 area, then it would have been a dermatomal pattern, not generalized impairment of sensations. So it fits more with mixed polyneuropathy rather than either plexopathy or radiculopathy, right? But again, if it was in a specific dermatomal pattern like S1 or L5 or S1 or L5, not generalized, then it would either fit with plexopathy or radiculopathy, or even maybe mononeuropathy. But in that case, both sides would not have been involved. Now we have answered both our questions. What is the lesion? It is lower motor neuron type weakness in both lower limbs. Where is the lesion? It is mixed polyneuropathy, means it is at the level of spinal nerves and both motor and sensations are impaired. Now, why is the lesions? What conditions can cause mixed polyneuropathy? Diabetes, alcohol related, it could be CKD related uremia, can also cause mixed polyneuropathy. It could be hereditary sensorimotor neuropathy. You must have heard the term Charcot-Marie-Tooth disease. And finally, it could be also due to CIDP. So these are the causes of mixed polyneuropathy. And if only sensations were impaired, motor power reflexes were intact, then also in that case, if it is in the form of glove and stroking, it would fit with polyneuropathy, sensory type weakness. And again, the causes would be the same: diabetes, alcohol related, uremia related, CIDP. Now, finally, to our last scenario, a patient presents with unstable gait. Now, again, you check for fasciculations. No fasciculations are noted. Check the bulk, it is okay. Check the tone, there is hypotonia. You check for power, and let's say power is reduced, again 3/5. Check for reflexes, reduced. Now you check the sensations, they are intact. And when you check the coordination, it is impaired. Coordination you check like this. अच्छा, यूं लगाना है आपने, यूं करके उठा के यूं रख देना, ठीक है? Let's suppose this side is impaired. There is loss of coordination on this side. Now you check the gait, and when you ask the patient to stand like this, their feet touching each other, looking at horizon, they sway to this side. They cannot stand straight. They fall on this side. They cannot fall straight, stand straight. It straightforward hits your mind that it could be related to cerebellar. Now you come to the upper limbs and you check for finger nose test. अच्छा, ये आपने उंगली नाक को लगानी है और मेरी इस उंगली को लगानी है, ठीक है? ठीक है, शाबाश करें, इधर मेरी उंगली पर लगाएं, ठीक है, ठीक है. So there would be pass pointing. When he will touch my finger, his finger will be like this. He will have difficulty in finding the exact point. Now we will check for dysdiadochokinesia, and again he will not be able to do that too. Since there is suggestion that there is right-sided cerebellar involvement, so it will cause ipsilateral defect. So all the features of incoordination will be on the right side. अच्छा, अपने हाथ को यूं लगाना है, फिर उठा के यूं लगाना है. Now we check the extraocular movements, mostly to look for any nystagmus. Let's suppose nystagmus is present too, and the fast component is towards right side. When he looks to the left, there is nystagmus present, and the fast component like this. When he looks towards left, slow component, and then fast component. Slow component, and then fast component, because the brain is trying to correct the movement. So in cerebellar lesions, the fast component will be towards the side of the lesion. So that was all about what findings will be present in cerebellar lesions, and they will all be towards the side of the lesion. Like in this case, we were suggesting that there is right-sided cerebellar lesion. It could be stroke, it could be hemorrhage, anything. And there was lower motor neuron type weakness, lack of coordination on right side, finger past pointing on right side, dysdiadochokinesia on right side, and nystagmus. When he looks towards left, the fast component is towards right. So that was all about lower motor neuron type weaknesses. We have already covered upper motor neuron type weaknesses in the previous lecture. You can find the lecture here. I know it all seems difficult on the first occasion, but you can watch it again and again, maybe even practice with your colleagues or friends or real patients. And trust me, it will become more of a habit. Like I stated in the first lecture, it will become 2 + 2 = 4.